Welcome, everybody, to the breakout session. I think I'd like to start by having everyone just briefly introduce themselves by their name and their institutional affiliation. Some of you were in the same group before, but there are some new people in the room, so we'll have everyone introduce themselves. I'm Anita Allen. I'm a professor of law and philosophy at the University of Pennsylvania and a member of the National Academy of Medicine. So how about we just go down the line? I see Barry next. And Barry, you want to go ahead?
I'm Barry Kohler from Rockefeller University, and I'm physician-in-chief and the principal investigator of our CTSA award from NIH.
Super. Jay? You're on mute. You're muted. There you go. Unmuted.
Okay. Jay Siegel. I'm now consulting and on boards, formerly 20 years at the FDA and almost as long as an industry R&D leader at Johnson & Johnson.
Lynn?
Lynn Matresian. I'm the Chief Science Officer at the Pancreatic Cancer Action Network.
Ethan?
Hi there, I'm Ethan Bash. I'm an oncologist and health services researcher at the University of North Carolina, where I am chief of oncology and physician-in-chief of our cancer hospital.
Great. Erica?
Hi, I'm Erica Brown. I'm the founder of Town and also One Cancer Place. I'm obviously a patient accumulator or aggregator is what I say. Thanks for having me.
Thanks, Valda.
Hi, I'm Valda Vinson. I'm editor covering life sciences at Science Magazine and here just to sort of be educated.
Thank you. Jonathan?
Hi, good afternoon. Jonathan Tobin. I'm a cardiovascular epidemiologist. Excuse me. I'm CEO of Clinical Directors Network, a primary care practice-based research network that works with federally qualified health centers and other safety net practices. And I'm Senior Epidemiologist and Co-Director for Community Engaged Research at the Rockefeller University Center for Clinical and Translational Science.
Richard? Richard, are you there? Can you hear?
Yes, hi. Rich Wachitsky. I am EVP for Science and Regulatory at Pharma.
Great. Adrian Hernandez?
Hey there, Adrian Hernandez, a cardiologist at Duke and director of the Duke Clinical Research Institute.
Great. Is it Ramit?
Yeah, that's right. My name is Ramit Zerpal. I am a clinical research project manager with UNC Health and the Office of Research Supporting Compliance.
Amanda and Esther, do you want to quickly introduce yourselves?
Just really quickly, I'm Esther Krofa. I serve as Executive Director of Faster Cures at the Milken Institute.
And
yep, Amanda G., staff at the National Academy.
Great, thank you. All right, there may be others on the call that didn't get a chance to introduce themselves, but feel free to speak. And when you make a comment, just introduce yourself when you make your first comment. So our goal here is to look at the potential to establish a clinical trials enterprise that is diverse, equitable, and inclusive. And some of the potential approaches that have been identified for us in advance are improving the engagement of underrepresented patient populations, lowering barriers to recruitment, enabling community-based providers in rural and underserved areas to participate, and engaging a more diverse clinical trials and clinical trials enterprise workforce. Interested in anything you have to say? And in particular, we're interested in technologies that you think would be useful for advancing these goals and these sub-goals. So I throw it open to anybody who'd like to get us started.
Well, I might say I combine our goal with the other goal that I saw mentioned because I think to address some of the issues that you laid out, it's probably important that we make sure that there are clinical trial sites and investigators that are well connected to underserved communities. I think at Pharma, we're particularly interested in what could be done to create an infrastructure, for example, that could locate clinical trial sites adjacent to the healthcare in those communities. We're also very interested in making sure that there are community relationship programs that existing sites could make use of to better interact with those underserved communities. I think in particular, being able to make sure that trust can be built, awareness of trials is provided, and to get at the accessible issue to make sure that, in fact, by having a close proximity in communities, that access becomes a much easierly achieved issue.
Did you say something about particular technologies which might make it more possible for this intersection?
Yeah, well, for example, Yale has a really interesting and successful model for how they have reached out to their communities that is underpinned by non-traditional partners in the community, but held together through a technology program using their EHR systems that are also used by the healthcare providers in those communities. And for example, I think it really helps identify for healthcare providers which of their patients might be approached appropriately for participation in clinical trials as a really important way to make the connections.
Great, thank you. Erica, did you have your hand up?
So can I add to that last comment? The HRSA-funded federally qualified health center network, I think, meets many of those criteria, many of the opportunities that Commissioner McClellan described in his talk in the last session. The footprint of HRSA, 1,200 grantees, more than 10,000 delivery sites that deliver community-based, accessible, culturally competent primary care preventive services, behavioral health services, oral health, pharmacy, etc. These centers, by regulation, have a community board that's at least 51% users. Virtually all of them now have electronic health records, though not the same health record, but in the work that we do at Clinical Directors Network, we've been able to integrate data across a wide variety of different EHR platforms and make the information interoperable. But to go back to the point of diversity, equity, and inclusion, there's a tremendously underappreciated workforce of clinicians and staff in those centers that have both the trust and the access to the community and incredible insight into disease implementation and outcome that with the right training and research design, we've developed several remote training opportunities, both synchronous and asynchronous, to build the clinical research capabilities of practicing clinicians. But I think there is a tremendous infrastructure already in place that does health services delivery in vulnerable, low-income, minority, medically underserved urban and rural settings, that with the right support of technology and people, and that also includes the kind of external practice facilitators that take the load off of the research experience and off of the clinicians and make research more accessible to both patients and clinicians.
Adrian, I guess one comment, having worked across a lot of those kind of networks or systems, is that they have a lot of resource challenges. So technology is not kind of the only requirement they have, because they certainly are serving an incredibly important and underserved population. And it's a setting where research where there are strategies of care fit nicely. But when you think about other types of trials, interventional trials of testing new drugs or devices that maybe, I'll just say, accompany a lot of other things, they may not always fit because they're trying to fit into, a busy set of practices here. So just thinking about technology solutions here is, again, where there things can be done more at home, where things can be met to the patient, and where things can be offloaded from these very busy healthcare centers. It's hard to squeeze more hours in the day. And so how that can be centralized, take those functions off of them and allow them to do greater patient care and engage on research. So just a few thoughts on crossing the different boundaries.
Erica, do you want to
Yeah, I sound like a broken record. I I'm a patient. I was a patient, and I'm here to tell you all that none of this works without patient education. Patients don't get up in the morning of a diagnosis and say, I think I'm going to get diagnosed today, and am I prepared to ask questions about clinical trials? Clinical trials don't even enter into the thought process. And until and unless we've really educated our entire population on everything, getting everybody geared up to realize that this is a national, global effort to defeat a disease, and hopefully it's my disease. It's all for not much. I mean, there's so many myths out there about what a clinical trial is that don't get really disputed. And it all comes down to that individual patient going into the oncology office for that first visit. And of all of the suggestions I've heard, the idea of the EHR somehow being implemented across the board, it's already there, seems to make the most sense to start that education, because it has to start somewhere. At the time of diagnosis, the patient is most aware of the mortality, the shock. I mean, you want to know absolutely everything you possibly can know at that time, and you're most willing to agree to just about anything, and you're most willing to learn at that point. So, I mean, I sound like a broken record. I'm always going to be advocating for the patient voice and patient choice. And I would like to see technology that is introduced to me at that moment. If it's EHR and I get it, I understand it, terrific. If it's something else that I can utilize so that I can learn, that's where it has to start.
Thank you. Thank you for that. Other comments? Lynn?
I can share an experience of a study that we made online, thinking that it would therefore be very available. It was, you didn't have to go any place, you could do things online, and kit was sent to your home, and we thought this was really going to solve a lot of those problems, but it still didn't get us that diverse, inclusive population that we were looking for. And so what we learned from that is that it takes an extra additional step. Simply having it online and accessible through the internet was not enough. And I don't know that I know the answers at the moment, but the things that we're trying are things like it has to be on your phone, and it's not just an iPhone, it has to be an Android phone. There are all sorts of kind of much more human interaction kind of things that need to be done in addition to it. So it's not just enough to make it accessible. It really has to go that additional step if you really want to have a population that's representative of the U.S. population.
One-on-one.
Yeah, the telephone point's interesting because it turns out that the vast majority of Blacks and Hispanics have Android phones, and iPhones are mostly a privileged upper class kind of thing. So there you go. Interesting points. I mean, it was a study done out of Emory that I learned about recently, where they researched. They were trying to establish whether people would be more likely to opt into research if they got their HIPAA notifications simultaneously with their informed consent. And what they discovered, looking at a group of African Americans who were hypothetically enrolled in a hypertension study, is that the people who were told about HIPAA in detail declined research more than those who just got the informed consent documents. That is to say, knowing more about how the researchers intend to protect your privacy and what your privacy rights might be might make some people of color less likely to engage in research than those who are ignorant as to their privacy and privacy rights. Interesting result. It was a small study, but a very, very interesting possibility to explore. Ethan?
Thanks. We've observed in trials that a highly purposive or targeted enrollment strategy with sites can be very effective in improving our minority enrollment in trials. And this entails a very low-tech strategy of really pushing CRAs and research leaders at sites to reach certain targets. It involves, at the inception of trials, getting estimates on population demographics for that site or for that practice, and then regularly interacting with the people on the ground who are approaching and enrolling patients. And, I think what we and others have anecdotally found is that a lot of judgments are made by research staff about which patients will be good and not good, or willing and not willing clinical trial participants. And, I think to Erica's point about providing education and information to patients, I think there's an analog for CRAs as well. And there's a real need to educate CRAs in the field that there needs to be an emphasis on equity and awareness of biases that people have when they think about approaching clinical trial participants.
Thank you. Those are excellent points about how to better access the relevant communities and get folks enrolled.
Can I jump in really quick with a comment that we just got from the webcast viewers pertinent to this discussion? Mary Tobin from online flags that there's also a cultural component to this, to think about cultural experts as part of this conversation, and wonders how that interplays with technology to solve this problem overall. Like, how do you consider cultural sensitivities along with technology improvements and changes?
Yeah, and there are a number of excellent books by people of color discussing the ways in which people of color engage with technology. And I think some of that literature should be part of the knowledge base of all the clinical trials research teams. It's very important. But do others want to comment on that as well? The cultural dimension, how we include the cultural competence dimension in some of this?
Well, it is known that there are differences between groups in how particularly mobile technologies are accessed and used. And that's been seen both between Black and white patients in the US, but also between urban and rural patients in the US. And, what's being recognized is that differences in how people access and use technologies, if not considered in implementation, can lead the digital divide to create further health disparities rather than narrowing them, which of course is the intention of these technologies.
I'd also note that we need to get way beyond the federal census categories of, Black, white, Asian, Pacific, Native American, if we're going to really take cultural competencies seriously. I mean, just looking at the Black population, there's so many different countries of national origin: the Nigerians, Ugandans, South Africans, Kenyans, people from Haiti, people from Puerto Rico, people from New York City, people from rural Alabama. And these groups are not all one big blob. They're not one culture. It's many cultures. And therefore, we start talking about the cultures of so-called Hispanic populations, which is really many, many different Spanish-speaking populations. You can't just reduce everybody to 5 convenient groups and think you've done your job. So the cultural piece taken seriously, it's going to be very, very contextual, very, very localized, and require a lot more people involved in our cultural competence teams than just.
Well, I think that's true. There's a fair amount of intersectionality. At the same time, we know that there are principal variables when it comes to patients accessing technologies, which largely relate to health literacy, education level, and prior technology avidity. And then there's an additional component around usability or access, which relates to, a person's resources for accessing a technology, because we know many patients who are paying for their own data and they're being asked to use their own device for, clinical trial or data collection activities, may be less willing, but also may not be may not be willing to disclose that information at baseline. And so I think that, for any of these interventions, looking at these basic variables to meet people where they are, understand what their technology accessibility and abilities are is really essential. And I think that, that paired with a very well-trained staff or a video for training, but ideally a human, can overcome many of these cultural barriers. We know that there does not necessarily need to be racial or cultural concordance between the person accruing to a trial or the person interacting with a potential participant, as long as the tenets of cultural competency and sensitivity are employed. And I think the same applies to engagement around technology.
Yeah, I wouldn't disagree with that. I also think that sometimes economic class may be a more important variable than race or ethnicity or language group. Yeah.
I didn't have another question from online, but one of the other questions that we were hoping this group would discuss is, could you say something about, in the last, I think we have about a minute and a half, who is positioned to make some of these changes? Who in the ecosystem is ready to implement some of these technology changes?
Who's the who?
I think it takes a broad partnership, is my own personal view. I think sponsors have to think about incorporating those technologies. The sites need to be online to do to incorporate the technologies. Patients need to have the right tools and education to do the approaches, and there are various organizations that can all work together. And of course, the regulators need to be on board, and somebody needs to provide some funding. So some of that may come from the sponsors, but some of it may also come from government agencies. So, I think if we're really going to make a difference and move the needle, we all need to work together and bring all of our different skills to the table.